Thank you very much, Dr. Muhammad. It's my honor and pleasure to be with you and to be introducing the assistant professor, Dr. Pedro Morgado. He is an assistant professor of psychiatry at Mino University and the psychiatrist at Hospital de Braga. To start with, I think it would be a great chance because I'm sure that he has used Mexazolam, Sedoxil in Portugal, because I think Portugal is one of the, I think it's actually obviously the manufacturer, the country of manufacturing, but also one of the European countries which has used Sedoxil for a number of years. So it is with great pleasure we introduce Professor Pedro Morgado. Welcome to the webinar, Prof.
Thank you very much. Good evening for all the participants, and good evening, Dr. Hussein Omar. I will share my presentation. As it was mentioned in the introduction, I'm from Braga in the north of Portugal. This is the hospital where I work, the School of Medicine where I teach, and a photo of my own city where I live. I'm very pleased to be here with colleagues from the United Emirates to discuss the state of art on the treatment of anxiety disorders. And I would like to acknowledge this, the invitation for this opportunity. The views shared in this presentation are my own and are based in my clinical practice and in the latest consensus that we use here in Portugal. In the next 30 minutes, we will talk about anxiety disorders, and I'll present the most relevant scientific data regarding the use of Mexazolam, a benzodiazepine, used for years in Portugal to treat anxiety symptoms and anxiety disorders. I have to say that Portugal is among the 3 European countries with the highest levels of anxiety disorders. So we have to treat some of these patients in psychiatry departments as well in primary care services. Anxiety is a very, very normal human experience that does not change so much with culture. We probably experience the same type of anxiety symptoms in Portugal and in the Emirates. Anxiety is defined as a subjective feeling of fear and discomfort. It is adaptive and is a universal response to threat or danger. As you certainly know, some anxiety is associated with optimal levels of functioning. Too low or too high levels of anxiety impact negatively in performance. When we are stressed, brain functioning is dominated by deeper structures such as amygdala, while when we are unstressed and relaxed, the thoughts, emotions, actions can be commanded by cortical areas. When anxiety is excessive and interferes with life functioning, we call it pathological anxiety, and it can be an indicator of a psychiatry disorder. In this state, we can experience excessive and unexplained anxiety accompanied by physical, psychological, and cognitive symptoms, which interfere with social and occupational functioning. Anxiety is a very, very heterogeneous condition that may present symptoms like excessive concern or feelings of apprehension, restlessness, impatience, easy fatigue, difficulties on concentration, muscle tension, sleep disorders, hyperactivity of the sympathetic nervous system, and a panoplia of other symptoms. Anxiety disorders share characteristics of excessive fear and anxiety and related behavioral changes that persist beyond normal. But different anxiety disorders differ in the types of objects and situations that can induce anxiety or avoidance behaviors, and in the associated cognitive ideation. I mean the associated thoughts and beliefs that cause anxiety. In this chart, we have the most updated classification of anxiety disorders according to the DSM-5. Recent classifications include disorders such as generalized anxiety disorder, panic disorder, and phobias. And there are other anxiety-causing disorders that were formerly considered anxiety disorders, but are now in separate categories. Although previously listed under the anxiety disorder DSM classification, obsessive compulsive disorder, post-traumatic stress disorder are no longer classified as such. So we'll take an overview on the anxiety disorders considered in DSM-5 these days. In generalized anxiety disorder, the key features are persistent and excessive anxiety and concern in several life domains, including work, school performance, social times, in which individual has difficulty in controlling what he is feeling or thinking. Patients can experience several physical symptoms. The ones we have seen some slides back: restlessness, inattention, easy fatigue, concentration difficulties, and feeling of being left with an empty mind, and of course, sleep problems. In panic disorder, the individual experiences unexpected panic attacks. Panic attacks are abrupt increases in intense fear or discomfort that peak in minutes and are followed by physical or cognitive symptoms. In social phobia or social anxiety disorder, the individual is afraid and avoids interactions and social situations involving the possibility of being observed. This includes social situations such as meetings with unknown people, situations in which you may be observed when you are eating or drinking, or when you are performing a task in front of other people. Here, the cognitive ideation is to be evaluated negatively by others, to be ashamed, humiliated, rejected, or offended. In agoraphobia, the fear is related with using public transportation, being in open space, being alone outside home in other situations, or being in a line or in a crowd. The individual fears these situations due to the thoughts that the escape may be difficult or that the help may not be available in the event of developing a panic attack or panic attack-like symptoms or other disabling or embarrassing symptoms. And finally, in specific phobia, persons are afraid from specific objects or situations. Contrary to what happens in other anxiety disorders, a specific cognitive ideation is not characteristic of this disorder. Fear, anxiety, and avoidance are responses almost always immediately induced by the phobic situation and persist at a disproportionate level to the real risk. Concerning the prevalence, anxiety disorders are highly prevalent in our population, affecting up to 15% of European population, and usually are more prevalent in females than in males. As we could see previously, anxiety disorders are like a big umbrella that covers several individual disorders. So it is not always easy to diagnose it properly, since the somatic or psychological complaints are vague or not specific. They are normally subjective. Another reason of the challenge related with diagnosing anxiety disorders relates to the frequent visits to doctors, usually requesting multiple diagnostic exams for different symptoms. In general, there is also a family history in patients with anxiety, and psychiatry comorbidity is highly frequent. For example, anxiety can happen as a symptom in 60 to 70 of patients with depression, and up to 60 of patients with an anxiety disorder could experience depressive symptoms. So the differential diagnosis is very difficult in some situations. When we are assessing an anxious patient, we should acknowledge whether the anxiety happens before or after a medical condition, or if it happens due to a side effect of a medication. We should keep in mind that anxiety is only diagnosed when the symptoms are no longer best explained by another mental disorder. The differential diagnosis of anxiety disorders involves distinguish anxiety disorders from other psychiatric disorders and from other medical disorders, including cardiac, respiratory, and endocrinological conditions. Concerning the treatment, several psychological and pharmacological treatments are available for the management of anxiety disorders. Treatment paradigms can include a combination of psychological therapy and various pharmacological therapies. The cognitive behavioral therapy is the most empirically supported psychological treatment for anxiety disorders, and antidepressants are considered the first-line pharmacological treatment for most anxiety disorders. First-line medications include the antidepressants, as I mentioned before, mainly the SSRIs and the SNRIs, as well as the benzodiazepines. While antidepressants are seen as long-term treatment, benzodiazepines could be used as adjunct medications in the early phases of the treatment. Treatment with SSRIs or SNRIs antidepressants only produce significant symptom reduction 2 to 4 weeks after initiation, and is frequently associated with usually transient adverse effects like insomnia, anxiety, gastrointestinal discomfort, and headache. These facts make benzodiazepines particularly useful in the initial phases of anxiety treatment. Almost all international guidelines identify antidepressants and benzodiazepines as effective and well-tolerated treatments for anxiety disorders with a level of evidence A. Concerning benzodiazepines, they are well-known drugs used to treat a myriad of different conditions. With the current availability of benzodiazepines, we frequently face difficulties in choosing the most appropriate drug for an individual patient. Therefore, it is important to have a good understanding of the main characteristics and differences between these drugs. Despite sharing the same mechanism of action, when choosing a benzodiazepine in clinical practice, we must take into account its pharmacology, which includes two main characteristics: the pharmacodynamic and the pharmacokinetic properties. Pharmacodynamics refers to the affinity of a specific benzodiazepine for different subtypes of GABA-A receptors, while pharmacokinetics refers mostly to the half-life of the drug. These are the differences that in clinical practice will translate into differences in their main therapeutic effects. Some are more anxiolytic and others are more hypnotic or sedative benzodiazepines. All benzodiazepines used in clinical practice have the ability to promote the binding of the inhibitory neurotransmitter GABA to the GABA-A subtype of GABA receptors. By an unknown mechanism, activation of the benzodiazepine receptor by its agonists increase the affinity of GABA for the GABA-A receptor. This means that benzos can act as depressors of the central nervous system, having anxiolytic or hypnotic actions. The GABA-A receptor is made up of 5 units that have a central chlorine channel. There are several types of GABA-A receptors depending on the type of subunits present. The type and function of each GABA-A receptor will depend on the subunits it contains. Benzodiazepines bind to the region of the receptor between the alpha and the gamma isoforms, one per receptor. GABA binds with two molecules between alpha and beta subunits. So depending on the type of subunits present in GABA-A receptors, these may have different functions. Benzodiazepine sensitive GABA-A receptors with alpha-1 subunits may be more important in sleep regulation and have more sedative properties. They are potentially the target of hypnotic benzodiazepines. On the other hand, benzodiazepine sensitive GABA-A receptors with with alpha-A or alpha-2 subunits may be more important in regulating anxiety and more likely to be the target of the anxiolytic benzodiazepines. Concerning pharmacokinetics, benzodiazepines can be divided into 4 groups depending on their duration of action. In this case, related to the plasma half-life of the drug. The ones with longer duration of action are more useful to treat anxiety, while the ones with shorter duration of action have indication to treat insomnia. In the clinical practice, benzodiazepines are the group of medicines most widely used in the treatment of symptomatic anxiety. Although they are safe, efficacious, and well tolerated, there are some issues regarding its clinical use. Concerns about possible abuse and dependence limit their use, and these drugs should be used with caution in individuals with alcohol or other substance abuse disorders. The risk of dependence and tolerance, meaning the need for a dose increase to obtain the same effect, exists and is related with each molecule properties. Addiction risk is mentioned for all benzodiazepines. Nevertheless, it has also been suggested that benzodiazepines with higher alpha-1 subunit affinity and higher sedative potency have an increased risk of addiction. Short and intermediate half-life benzodiazepines may also have a higher risk of dependence than the long half-life benzodiazepines. And the risk of developing dependence is also higher in chronic treatments and in patients with previous history of addiction and drug abuse. Other cautions should be observed. Benzodiazepines should not be prescribed in some situations, such as myasthenia gravis, the severe respiratory failure, hepatic insufficiency, and sleep apnea. The use of benzodiazepines should also be discouraged in liver function problems and also in the concomitant use of alcohol. In pregnancy, we should evaluate carefully the benefit-risk ratio before using this type of drugs. In the next part of this presentation, I will share with you our experience with Sedoxil and also the evidence that supports its efficacy and tolerability in the clinical practice. Mexazolam or Sedoxil is indicated for the treatment of anxiety, either in the context of an anxiety disorder or as a symptom of other psychiatry disorder. It has strong anxiolytic properties. In preclinical studies, Mexazolam was found to be more potent than diazepam in tests measuring the anxiolytic effect. And it has less sedative and muscle relaxation effects than other benzodiazepines. It was also found that Mexazolam has had less ability to sedation and muscle relaxation when compared to diazepam, for example. After repeated administration, the half-life of its active metabolites is long. It is considered a benzodiazepine with long duration of action. The efficacy was proven in several clinical trials. In this multi-center trial with over than 400 patients, several symptoms associated with anxiety were reduced by the administration of Mexazolam. Patients received 2 or 3 milligrams each day of Mexazolam, and the highest percentage of symptom reduction was observed in asthenia, headache, distractibility, irritability, restlessness, palpitations, and thoracic pain. Looking at the results from the mean scores of the Hamilton Anxiety Rating Scale, the efficacy of Mexazolam in the treatment of anxiety disorders was also confirmed. From baseline, a 30% reduction in the Hamilton scale was observed at day 7 and a 57% reduction at day 28. So we can assume that the anxiolytic effect of Mexazolam was fast, with this 30% reduction in the Hamilton score at the end of the first week of treatment. Other studies compared the efficacy of Mexazolam with other benzodiazepines. In this comparative study of Mexazolam versus alprazolam, a multi-center randomized clinical trial that lasts for 5 weeks and included 64 patients with generalized anxiety disorder was performed. Patients received 3 milligram each day of Mexazolam and 1.5 milligram of alprazolam each day. The study revealed an absolute higher responder rate in the Mexazolam group when compared with the group taking alprazolam. Although these differences were not considered to be statistically significant. So the efficacy of Mexazolam in anxiety symptoms reduction is comparable with alprazolam. In a more recent work presented at the European Congress of Neuropsychopharmacology, the affinity of Mexazolam and alprazolam to different subunits of GABA-A receptor was assessed. Alprazolam has a greater affinity to alpha-1 subunit, which may explain its greater propensity to induce sedative adverse events when compared with Mexazolam. Mexazolam has a greater effect on both alpha-2 and alpha-3 subunits, which may explain its greater anxiolytic action when compared with alprazolam. In this other study that includes 60 patients, the efficacy of Mexazolam was compared with bromazepam. This study lasted for 4 weeks, and the Hamilton Anxiety Scale was the instrument of evaluation. A statistical significant reduction in the Hamilton Anxiety Scale score was observed throughout the weeks and was higher in patients receiving Mexazolam than in patients receiving bromazepam. So in this particular study, Mexazolam showed our higher efficacy when compared with bromazepam. Concerning the tolerability, in this randomized double-blind placebo-controlled study, 30 healthy volunteers performed a set of tests to assess psychomotor performance. After performing an initial set of tests, each volunteer randomly received a single oral dose of Mexazolam 1 milligram or placebo, and 3 hours later, the same set of tests were cross-replicated. As we can see in this slide, in the car driving simulation, Mexazolam does not have psychomotor performance impairing effects at therapeutic doses. The results of this study also highlighted that Mexazolam produced reduced effects on psychomotor ability since there were no statistically significant differences between placebo and Mexazolam in all the assessed parameters, which included the recognition reaction time, the motor reaction time, and the reaction total time. In another multicenter randomized and double-blind study, 60 patients with a generalized anxiety disorder participated in a set of tests to assess the psychomotor performance. Mexazolam produced reduced effects on psychomotor ability. As we can see here, the lines basically overlap, meaning effects very much alike from Mexazolam and for placebo. In another study, with over than 400 GAD patients, the cognitive function was evaluated. A memory test assessed through the number of word recall of each patient was performed and rated. No decrease in cognitive function was evidenced in the memory test. On the opposite way, a positive effect of anxiety reduction with Mexazolam resulted in a significant improvement of memory performance in this test. Altogether, this data and these informations make Mexazolam a current drug in our clinical practice. Mexazolam should be used in a very personalized way, according to the patient's age and the severity of symptoms. The starting dose should always be the minimum recommended, and then it can be adjusted according to the patient's response until the maximum recommended dose. A maximum daily dose of 3 milligrams given in 2 or 3 divided doses is recommended for adult patients. In elderly patients, the dose should be lowered and adjusted to a maximum of 1.5 each day. Mexazolam is not usually used in pediatrics, but here in Portugal, we are still using it for adolescents that have higher performance in the school, because as it is less sedative than other benzodiazepines, the cognitive function is preserved, and they can have better results in the school. In summary, Mexazolam can effectively treat generalized and social anxiety, panic disorder, and anxiety in the context of other psychiatric disorders. It's well tolerated both for young active patients and for older adults. Its reduced effects on psychomotor performance and cognitive function may lead to better compliance. Unlike other benzodiazepines, such as alprazolam or bromazepam, the risk of rebound symptoms between doses, the risk of misuse by the patients, and the risk of developing tolerance and dependence is extremely low. Altogether, these characteristics make Mexazolam a benzodiazepine of choice in the treatment of anxiety. Patients can experience more freedom to live, and doctors can experience more security in the prescription and more freedom to decide when to start and when to stop this type of medications. These are the views I have to share with you, and now I'm available for questions and comments and for the discussion. Thank you very much.
Thank you very much, Professor Morgado, and we will